One is transfusion syndrome. Then I had one on urinary tract obstruction. And then you had thorax, CDH, and non-CDH. So we will have to make a choice that one will be dropping. I would start with twins because I think twins is an accomplished therapy. Everybody should recognize it. And the question is today, what is new since the randomized trial? And that I think is the most important, because everybody must know that. So the good thing is that for twin transfusion syndrome, there is a good background information, but just reminding you of the criteria. It's polyuric polyhydramnios with oligouric oligohydramnios, and in Europe we use this difference of 8 and 10 centimeters under and above 20 weeks. In the United States, and I assume you live under that influence, you may be using a other criterion. We always have to remind referring physicians growth restriction is common, 25%, but it's not part of the criteria. The procedure is straightforward. It is looking at the anastomosis, finding them, and coagulate them all. It's as simple as that. There is no good and bad one. They just all have to go. That means that you will have to be able to see, and that is not always possible. The trial showed that there is a reduction, there is an increased survival as compared to amnioreduction, an increased gestational age at birth, and as a consequence, there is a better neurological development. That now has also been supported by good data. The people have to realize when you refer a transfusion syndrome, there is a 25% mortality still. And that mortality is in part due to technical reasons. We know that transplacental trocar insertion is a predictor of poor outcome. Very early presentation uniformly gives lesser good results. There is the problem of rupture of the membranes that is unavoidable, which also exists with amniodrainage, of course. The main determinant is the cervix. When there is a short cervix, the operation can be successful, but the woman can still miscarry. Then there is things you cannot change. I find them completely useless to have a philosophy about them because you cannot change them. But anyway, poor Dopplers in the donor predict a poorer outcome. In the recipient, it is a little bit less certain. There is now good work being done and underway for publication from different teams on Dopplers after the surgery. They matter. Not these, because we cannot change them. Post-operative problems that you can see, and as a referring physician, I think you should know them. When you see chorionic amniotic membrane separation, you know there is an extremely high risk now for preterm delivery. Then there is the risk for recurrence or persistence. That means that the surgery was incomplete, and there is a 6% risk of anemia, which you have to screen for by middle cerebral arteries. There is a problem of around 10% right ventricular outlet tract obstruction in the ex-recipient. So you must look at their cardiac function and their cardiac Dopplers in the follow-up period, because they may require help after birth. Now, what can we do about that? Transplacental access, well, the simple fact is try to avoid it. Can we do something about the membranes? Well, there is some news about that, and I will give that at the end. What can we do about the cervix? Well, there is some early information on cervical cerclage. And what we can do to avoid this is try to be better in our surgeries. Let me explain that. So I will talk to you about follow-up studies. What is the relevance of the Quintero stage, new instruments, and then these two issues that I just mentioned. In terms of follow-up studies, the Eurofetus trial cohort was followed and was physically re-evaluated at 5 years, and the number of neurologically impaired babies was higher than expected, but still the difference is significant. After successful laser, there is a 12% neurological problem, significant neurological problems, which is nearly 20% after drainage. And you see that it actually is stable from 6 months onwards. These are months. And you see here that laser versus drainage keeps its difference over the time. And usually there is not much that happens in the later time period. What is interesting in that data set is that the stage of the disease is predictive of the neurological outcome. Stage 1 and 2 combined did better than stage 3 and 4. That brings me to the staging system. There is a true war about who has the right to classify this disease. And this is Ruben Quintero's staging system based on amniotic and bladder fluid volumes, and stage 3 and 4 based on Dopplers, wrongly pooling venous Dopplers with arterial Dopplers, and then describing hydrops as an end stage of the disease prior to fetal death. At this moment, we can say that for daily practice, stage does not matter. When you diagnose the disease, irrespective of the stage, the advice is the same: offer laser. And these data show that. There is a stage-dependent decrease in survival, but even in the worst stage, 1 out of 2 pregnancies will have 2 survivors. So there is no need to offer feticide at all in any of the stages. There is, however, discussion about the stage 1 of the disease, which is probably more an emotional one, but anyway, we gave in to that. And there is an Eurofetus 2 trial now underway. It will open very soon, and we really invite the fetoscopic laser guys here in this country participate in that, please. It's an open trial. These are the criteria. You will have to stick to European criteria. And what will be done is either there will be immediately randomized to laser, or the patient will be observed once or twice a week. And if there is progression to stage 2, or there is maternal discomfort and cervical shortening, the patient can be crossing over to laser. And the endpoint is again the same: intact survival at 6 months of age. There are new instruments, and this is a clinical picture, already old. You see an old Ackerson machine, but this was a patient that had a bit of an uncomfortable BMI and a very huge polyhydramnios, and you can already imagine that your scopes are too short. And as you can see here, I really had trouble to get the entire placenta. And so we have adapted to American reality. And this is the new kind of scope, American reality. It's a pistol grip. I mean, it shoots easier, they know that. And the length is 10 centimeters more to tackle obese women. And it also has the possibility for the same diameter to give full irrigation, and whatever you want to do, you can do it through that scope, and the lens is new and the vision is improved. Then there is the issue of how to coagulate. I mean, typically when there are 5 surgeons, there are at least 6 techniques, and one is certainly better than the other. Historically, we started by coagulating along the membrane. Then everybody realized you had to do it like the equator, and then there are selective, non-selective, super-selective, sequential lasers. For those in the room that are not doing this, I will try to explain this. This is a placenta of a twin-to-twin transfusion syndrome. This is an artery-to-vein connection, and these are AA and VVs. They run on the surface. This dips into the placenta, but when you cut it here, the sharing is stopped. It's as simple as that. You have a vascular equator which divides the placenta in 2 parts, as you see here. That equator is just there. You cannot change it. And then you have here the anastomosis, an artery-to-vein anastomosis. There you see other type of anastomosis. And you will have to keep that in mind when we go through the different techniques. Now, the problem is that the vascular equator has nothing to do with the membrane equator. The membranes may hide part of the placenta. And if you can only see this part of the placenta, you cannot see anastomoses that are behind the membranes. This one you will not see. So when you are unselective, that means that you are dividing along the membranes. Not that many people do that, but it exists. That will mean that this part of the placenta is cut off, and that part will be left here. You see that the baby may end up with a smaller placenta than desired. I will try. This is a drawing of a more selective technique. These are the two equators. Here you see that we first tackle the AV anastomosis, if we could see it, and then we would go for the other type of anastomosis. And if there are AVs in the other direction, they come between this point and that point. Everything is meant to increase survival by the prevention of exsanguination during the procedure. Because you can imagine if you coagulate in one way, the blood can only go from one fetus to the other and cannot return anymore. And that is where selective lasering comes from. So that is a selective technique that you see here, and that one, in this case, was invisible. So in reality, if we cannot see it, we will coagulate here, and all these ones are selectively taken. That one will be left behind. That's the reality that we will usually be doing, a combination of properly identified anastomosis and a pragmatical approach where you cannot see it, you still cut because you don't want to leave anything open. The end result is that you should have a complete separation of the placenta. We know it is not true. If you have not injected your own placentas, you don't know how good your surgeon you are. It's the same for cancer. When the section plane is positive, you are embarrassed, or you should be, and you will know that the outcome is not the same. Now, there is a discrepancy in numbers. How many do you leave open? If your name is Ruben Quintero, it's 4%. If your name is Yville, it's 23%. Is one better than the other? No, they just use another technique to visualize persistent anastomosis. What Lisbeth Lewy did in our department, and she was not a surgeon at that stage, so she was completely unbiased, is injecting placentas with double survivors, and we saw around 19% of persistent anastomosis by using pressure. Ruben injects air, and then you don't see all the vessels. It's as simple as that. But anyway, if you leave anastomosis behind, and they can be big ones, small ones, combinations, you're going to have different clinical results. And if you leave big ones there, usually both babies will die. If you leave smaller ones, you will have either top sequence, either before birth or after birth. And that's basically what is happening. When you see recurrence, discordance in hemoglobin, we know we have left anastomosis. So the idea was, and that's also a randomized trial that is going on, is to separate the placenta better. This is a lasered placenta, and you see all the laser impacts. But what we said is the better would be is to draw a line here. Even the tiniest anastomosis that is in between would then be coagulated. And this is how we do it today in this Solomon trial. You really make a division between the two parts, and you cut the placenta in two. And let's hope this thing starts. It's basically connecting all the laser points one after the other. What we know is that you should still refer your laser cases to one or a few places. I don't know how many centers you have here for 50 million people, but you can afford a few. But you see here, the more you do it, under 70, more than 200, the number of double survivors increases. So experience learns, and probably it is selectiveness, because you see that the number of patients with a single survivor is better after some experience than at the beginning. And that is probably what plays a role. This is important not only for survival, but also for neurological outcome. Look here. The number of impaired babies is less after a significant experience. Then to finish, some other news. What about the cervix and what about the membranes? Well, there was an observational study that in cases where patients had very short cervix, here in this study, it was shown that patients that had this short cervix, that of course many of them would deliver early, but still the number of patients that miscarries and loses their babies is very low. So that means that a short cervix is not an exclusion criterion. You should still do it, but you must accept prematurity. So laser is an option even for the short cervix. But perhaps if we diagnose the short cervix, and in this study from Paris, they said, what about doing a cerclage? And I know it's a big debate in twins whether you do the cerclages at all, but in this condition you may consider, because in this cohort study where you only have to read this, patients that had a cervical cerclage delivered 7 weeks later than those without cerclage. And that is observational material. This should be done in a randomized study, and Paris at least said that they would organize it. The last thing, if you have membrane rupture, there is something we can do about it. We can do amniopatch, another Venezuelan invention. Ruben Quintero described this procedure where actually blood platelets and plasma, that's what you do in real life. You don't use cryoprecipitate anymore. You can read it up online. It's now in prenatal diagnosis what amniopatch is and how you can do it. And what we have seen in this review is that after fetoscopy, after laser surgery mainly, in 2 out of 3 patients you can stop the membrane leakage, which still is a problem for the other third, but the procedure has a risk for intrauterine fetal death of around 10 to 12%. When you have the same procedure for genetic amniocentesis, you have the same number. The success is always the same. It's 2 out of 3. It doesn't work for spontaneous rupture. So to finish, we are at this moment also looking at the value of, I wanted to show, of putting in a collagen plug, but at this moment, this should be done within a trial as well. This would be secondary prevention of membrane leakage. On the way out, you seal the defect. So that's what it is about twins. I hope I was more or less in time. If there is any question about twins, please fire them.
Doctor.
Profesor, buenas tardes. Hay un aumento en algunos reportes, informes acerca de la evaluación ecográfica de los volúmenes de flujo a nivel de la vena umbilical, con el ánimo de, entendiendo que es un problema vascular, básicamente el del twin, poder, primero que todo, pues, determinar realmente el grado de compromiso que tiene la circulación fetal de cada feto, y con el ánimo, además de eso, de poder decir de pronto intraoperatoria o posoperatoriamente si la cirugía realmente modificó esos niveles de flujo. Hay algunos reportes en la literatura y hay bastantes trabajos recientemente sobre eso. ¿Cuál es su impresión al respecto y si hay algún trabajo en desarrollo o conoce algo al respecto?
Okay. According with what doctor said, which one is the real role of the Doppler and the umbilical hemodynamics in the fetus, in the both fetuses before and after laser surgery, and which one will be the best way to monitor that?
Yeah. Well.
Umbilical vein.
Yeah. Oh, you don't talk about arterial Dopplers, but perhaps I should expand a little bit on both. Now, in the preoperative phase, in the recipient, the umbilical vein as well as the ductus has some predictive value, but the studies are controversial. So in terms of predicting fetal death, this is fetal death. In terms of predicting neonatal death, which is something different, the venous pulsation, this is data from Japan on 200 lasers that they looked at in the first 7 days after laser, and then in the second week after laser and later on. This is important because this is when the patient is back with you. The venous Dopplers in the recipient were predictive of outcome in the early postoperative phase, but not in the late. Now, the reason why this would be is completely speculative. On the arterial Doppler side, your arterial Doppler predicts growth restriction, obviously. Before, it also predicts death. Afterwards, the situation is different between the first 7 days and the last and 7 days onwards. In the work from Gratakos, to which we participated, it was described that hydropic signs in the donor were actually a benign sign, probably volume overload, etc. And usually it goes away in the first 7 days. If it persists longer than 7 days, these Japanese studies showed that the baby is at risk for sudden intrauterine fetal death for unknown reasons. This means that with you, when you see persistent hydrops, you will monitor this patient because you will already in the viable period and you may want to deliver then the twin set. That's basically what it says.
¿Alguna otra pregunta para el doctor? Doctor Otero.
En su protocolo hay uso de la función cardíaca fetal para predecir cómo va el feto intraoperatoria o en el postoperatorio.
Are you using right now MPI in order to know all the cardiac function during the laser procedure?
No, we actually do this as a research tool. I don't say it would have any value, but for me as a surgeon, I have difficulties to understand how I would use this information during the operation. In a way, it would be, I think we should use it to document the value of, for instance, sequential lasering. It must have a difference. And it will help us understand, to show and understand why babies die in the immediate or postoperative phase. That it may help, but during the surgery, no, at this stage we don't do it. It would also prolong the surgery tremendously. Yeah?
¿Pudiese cambiar en qué cantidad de láser hacen ustedes en los vasos o el número de coagulaciones que están haciendo cuando están monitorizando la función cardíaca? Porque el cambio puede hacer que eso suceda.
According with the MPI during the laser procedure, could you change the number of bases you are going to laser or the number of anastomoses you are going to laser during the procedure?
I mean, in essence, we need them all. You can only argue about the order in which you will do them. So what I think is what we have learned from Ruben Quintero is that we now go in with a large endoscope of 2.9 millimeters and first try to find all the vessels, because with 30% more diameter of scope you see better. I had difficulties to admit this, but I am doing it now. We see better, and then we go back and try to laser everything. In that trial where we make a division along the membrane, along the vascular equator, that problem is of course solved. Then you just cut placenta in two.
¿Alguna otra pregunta del auditorio? Doctor Victoria.
En pacientes con síndrome de transfusión fetofetal estadio 1, ¿usted considera que ese momento es prudente para realizar una intervención con láser o es preferible esperar y mirar el desarrollo de la patología?
What do you think, doctor, about TTTS stage 1 in order to the treatment? Should we wait and make an
you should put the patients in the trial, because all the data show actually that stage 1 and stage 2 are equal and in a way should be treated likewise, because there is really no data that shows that stage 1 is harmless. On the opposite, in the randomized trial of Eurofetus, 2 stage 1 fetuses died between diagnosis and laser. So I think the only way to solve that is put the patients in the trial. It's an open trial, they are welcome.
Okay, doctora Mónica.
Doctor Représ, ¿cuál es la experiencia de ustedes en pacientes con estadio 4 con hidrops alrededor de las 26 semanas?
Which one is
¿Están
your-
intentando cirugía fetal en ese periodo, 26, 27 semanas?
Yes, I mean, every hydropic fetus makes no chance at that gestational age to be managed ex utero. It will have to recover in utero. We actually laser to 30 weeks. Yeah, it's just more difficult. The Leiden group has good experience, I think already published.
¿Alguna otra pregunta? Ok, muchas gracias. Continuamos.
We are far behind. We have to make a choice. Do I go for diaphragmatic hernia first?
Whatever you want, it's okay.
No,
for
I
us.
mean it's your forum. Yeah. Okay.